Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Junge Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor Steven Tong in Melbourne, Victoria, Australia, in order to discuss treatment of Staphylococcus aureus bacteremia based upon the first results from his Schneppe trial network, which have been published a few weeks ago in the New England Journal of Medicine and Lancet, respectively. Dear Steven, it's a real privilege for us to host the global leader in research on Staph aureus treatment at our channel.
Professor Steven Tong is an infectious disease physician with the Victorian Infectious Disease Service and co-head of the Clinical and Health Service Research at the Doherty Institute in Melbourne, Victoria. He conducts global clinical trials for common infectious diseases, and he leads the Staphylococcus aureus network adaptive platform Schneppe trial.
Well, thank you very much for the introduction, and thank you for the welcome and the opportunity to come and speak at the Marcus at Home webinar. So I'm really excited to do so, and to do so with hosts who are in the area of infectious diseases and nephrology, which obviously our studies touch upon both those parts of medicine. Here are my conflicts of interest. And I will talk a little bit about the burden of Staph aureus bloodstream infections, the Schneppe trial, and then go into the results which we have recently published about methicillin-susceptible Staph aureus and penicillin-susceptible Staph aureus, and then just briefly paint some of the new areas that we will research. So Staphylococcus aureus, of the top 33 bacterial pathogens outside of tuberculosis, it's the one that causes the greatest burden of disease. So here is a list of those top 33 bacterial pathogens, and then on the y-axis is the number of deaths estimated to be caused by each of these per year across the world. And you can see the one on the far left, the most common cause of mortality is Staph aureus. It's the only one that's estimated to cause over 1 million deaths per year, of which approximately 300,000 are due to bloodstream infections. This is some data from the province of Ontario in Canada. On the x-axis is the number of positive blood culture episodes for any particular organism. And then on the y-axis is the mortality rate for each of these episodes. So you can see that E. coli is the most common and Staphylococcus aureus is the second most common. But because Staph aureus causes almost double the mortality of an episode of E. coli bacteremia at about 20 to 25% per episode, it has the largest absolute size of the circle, which relates to the absolute number of deaths. So in terms of bacterial pathogens causing death due to bloodstream infection, Staphylococcus aureus is the most important and most common and one of the most deadly. And so this is a very common, very high mortality disease. Despite that, it hasn't been terribly well studied. There's been less than 4,500 patients who've been randomized in Staph aureus bloodstream infection trials. So when you think about some of the big cardiology trials, those trials exceed, all the patients studied with Staph aureus bloodstream infection. And that's something that our community in infectious diseases and microbiology has not done very well in studying this condition. And this led two editorialists, Tom Holland and Vance Fowler, to highlight in an editorial in the Lancet almost 10 years ago now that we need clinical trials networks of experienced sites to prioritize pressing clinical questions and conduct pragmatic trials. And ultimately, that responsibility falls upon us as the clinical community. I've also become a very strong advocate for this statement that it is better to provide randomized care rather than random care. So we will talk about, cefazolin versus cloxacillin. Prior to the Schneppe trial, at my hospital and hospitals all around the world, people would randomly choose to use cefazolin or to use cloxacillin or flucloxacillin, very much dependent on which individual clinician, which trainee was taking the attending or the consultant to see the patient, was really how we chose which drug to use. However, you randomize that decision and follow for the outcomes for each of those patients, If you get enough patients over time, you will learn from that and you will work out which might be the better treatment. So we set up the Staph aureus Network Adaptive Platform trial. It's a platform that studies the disease and not just one single question for that disease. And so here on the rows, we have the different antibiotic susceptibility profile, either penicillin susceptible, methicillin susceptible, or methicillin resistant Staph aureus. And then in the columns, we have different treatment domains or different treatment questions that we can ask of each of these patients who has each of the subsets of disease. So there's a domain which we look at the best backbone antibiotic. There's a domain for adjunctive treatment with clindamycin. There's a domain to look at whether we can switch to oral antibiotics safely at an earlier stage. And there's also a diagnostic domain that we've introduced to look at the utility of PET CT scan. Also, the study is across all ages. It's not just adults. All the protocols are harmonized to be able to include pediatrics as well. And today, some of the results I present will be about this PSSA silo, flucloxacillin versus penicillin, and for the methicillin susceptible Staph aureus silo, flucloxacillin versus cefazolin. This has quickly become a global study. We commenced enrolment in 2022 in Melbourne in Australia, but now it's a global trial with over 150 sites across 15 countries in the world. And more recently, France and Spain have joined also. So it very much is a global trial now. Here's our cumulative enrolment curve. We started in February 2022. On the x-axis are the months of each of the years from 2022 to 2026. And on the y-axis is the cumulative number of participants. The dotted lines at the bottom relate to the numbers recruited to the largest clinical trials for Staph bacteremia up till this point in time. And the dotted line in the middle there, around 4,000, that's when you combine the numbers of all these previous trials. So the SNAP trial has now exceeded the size of all previous trials combined. We have screened over 20,000 participants. Of these, over 6,000 have been enrolled into what we call the randomized platform. And you can see the different numbers who have gone into that backbone domain, adjunctive domain, early oral switch domain, and the PET CT domain. For patients who are either not eligible or do not consent to this randomized platform, they can go into a prospective observational registry, and we have now approximately 7,000 patients into that observational data set as well. So the first question we wanted to ask was cefazolin versus flucloxacillin or cloxacillin for methicillin susceptible Staphylococcus aureus. We did a survey via mainly Twitter about 3 or 4 years ago, where we asked over 2,000 participants around the world, what is your first choice antibiotic for methicillin susceptible Staph aureus bacteremia? Is it an anti-staphylococcal penicillin like cloxacillin or flucloxacillin, or is it a first generation cephalosporin such as cefazolin? And you can see that there's a lot of variation across the world. People from North America, 80% would choose cefazolin, whereas in Australia and New Zealand, and in Europe as well, about 80% would choose an anti-staphylococcal penicillin. So I think this is a great example of equipoise. It's also a great example of variation in care because we don't actually know which option is better. One of the theoretical concerns with using cefazolin is that some strains of Staph aureus produce a beta-lactamase that can hydrolyze very rapidly cefazolin. And so in the laboratory, when tested at a standard inoculum in the test tube, we get a certain minimum inhibitory concentration for cefazolin. So that can be quite low. However, if it's incubated at a high inoculum and there's a large production of this type A beta-lactamase, then suddenly that minimum inhibitory concentration can leap up to 16 or higher. So it's a theoretical concern that in a patient, if they have a strain that displays this cefazolin inoculum effect, perhaps cefazolin will not be as effective, and particularly for high inoculum infections, such as infective endocarditis. So we started the trial, as I mentioned, back in February of 2022. It uses an adaptive Bayesian methods to do the statistical analyses. And after every 500 patients or so, the Data and Safety Monitoring Committee has an interim analysis performed to look at the results. At the fourth interim analysis, they then asked the trial to pause recruitment to the PSSA and MSSA backbone domains because of some safety concerns relating to acute kidney injury. About 7 weeks later, with a bit more data at hand, they then had another look at that data and at that point asked the trial to close, not just pause, but to close enrollment to these backbone domains due to an increased acute kidney injury signal with flucloxacillin. At the same time, we had actually met a non-inferiority trigger for 90-day mortality in the MSSA silo. So at this point in time, we had over 2,600 adults in the randomized platform, of which MSSA was 1,757, and of those, 1,341 were randomized to either flucloxacillin or to cefazolin. These are the baseline characteristics of those participants, and they largely reflect what we would expect in a group of patients with Staph aureus bloodstream infection. So median age in the mid-60s, the majority are male at birth, and that's consistent with all kinds of other cohorts with Staph bacteremia, and you can see the range of other comorbidities. Importantly, for this part of the trial, we excluded patients who were on dialysis because we didn't feel it was ethical to give those patients flucloxacillin in terms of saving the veins of those patients. Cefazolin can be given 3 times a week post-dialysis as a very effective regimen, so we did not include that patient group. This was the focus or the types of infection involved, and again is broadly reflective of, it's quite representative of what usual Staph aureus bacteremia patients look like. So about a third have osteoarticular infections, about 25 to 30% have a skin and soft tissue infection, about 8% in our case had infective endocarditis. So I'm just going to go to the outcomes. The primary outcome was 90-day mortality. And we found that in the cefazolin group, this was 15%. In the flucloxacillin group, this was 17%. So higher with flucloxacillin. And when we place this into the statistical model, the adjusted odds ratio, where an odds ratio of less than 1.0 shows better, cefazolin is better. So 0.81 was the adjusted odds ratio. And we can derive a posterior probability for a non-inferiority margin of an odds ratio of less than 1.2, which is in fact actually a very tight mortality margin. If we convert that to an absolute mortality margin, it's about 2.5 to 3%. So it's quite tight to be able to say that it really is non-inferior with a posterior probability of 0.99 or 99%. And the posterior probability of, in fact, it being superior is about 90%. And we can represent this graphically. This is the posterior distribution curve of that treatment effect. 1.0 would be there's no difference in treatment effect. And the amount of this distribution that falls to the left of that dotted line is the probability that it is non-inferior. So 99% of this curve sits to the left of that line. And to determine how the probability of superiority, we could draw a vertical line at an odds ratio of 1.0 and look to see how much of the curve lies to the left of that line. And indeed, it is about 90%. Here were key secondary outcomes, and of particular interest was that for acute kidney injury. And this was why the Data and Safety Monitoring Committee stopped the trial. So this occurred in 19.1% with the flucloxacillin group and 13.7% in the cefazolin group. The numbers in terms of renal replacement therapy are too low to make a statistically robust comparison, but numerically, we did see a little bit more need for renal replacement therapy in the flucloxacillin group as well. And again, we can represent this graphically, and we can see now that for the outcome of acute kidney injury, the vast majority of that distribution curve lies to the left of 1.0. And we can quite confidently say that cefazolin is at least non-inferior and almost certainly superior with a posterior probability of 99%. When we look at the stage of acute kidney injury, and this is using a modified KDIGO score, so stage 1 is when it's between 1.5 times and 2 times the baseline creatinine. We can see that most of the acute kidney injury was stage 1, and there was a few that were stage 2 and 3. And we can talk about this later. One of the pre-specified subgroups we looked at was in particular was patients with endocarditis, again because of that theoretical concern about cefazolin inoculum effect, and we found that the direction of treatment effects was the same for patients with and without endocarditis. Of course, with endocarditis, the credible interval is wider because we have much fewer patients, but at least the direction and the magnitude of that treatment effect is consistent with the rest of the patients. So our conclusions are that cefazolin is non-inferior to flucloxacillin in terms of mortality, and it's superior in terms of acute kidney injury. And I think we can quite safely say now from both this study and other studies that flucloxacillin is actually a truly nephrotoxic drug, and therefore cefazolin should be the new first-line standard of care treatment for MSSA bacteremia. Going to move on to the comparison of benzylpenicillin versus flucloxacillin for PSSA. This slide is to remind us this is the agar plate from Alexander Fleming back in 1927. And if you remember the story, he had his window in his lab open, he had this agar plate. And in fact, what is growing on this plate at the bottom there are colonies of Staphylococcus aureus. But then there's a big blob up the top, and that is the penicillium mold, which is producing something into the agar that is causing the Staphylococcus aureus not to be able to grow up to that penicillium mold. Of course, that ends up that what is in the agar there is the drug penicillin. And this is to remind us that Staphylococcus aureus used to be susceptible to penicillin. And of course, with antimicrobial resistance, we've seen resistance develop to things like penicillin, to flucloxacillin, and to MRSA. What is somewhat surprising in this era of antimicrobial resistance is penicillin susceptibility is actually increasing. This is data from this Sentry program with centers globally across the world. And we can see that over time in the last 20 or 30 years, the proportion of methicillin susceptible isolates, which are in fact also penicillin susceptible, has been increasing over time. I don't understand why this is happening. No one's been able to explain it to me, but it is a very consistent observation across the world. So we were therefore interested in asking the question, can we use benzylpenicillin for these patients? One of the tricky bits about this is in the laboratory to test for penicillin resistance or susceptibility is a bit more complicated, and it needs a phenotypic test instead of just the automated test with the Vitek or Phoenix systems in the lab, that you need to plate out the Staphylococcus aureus on a plate with a penicillin disc, and you use that to read and to confirm whether an isolate is penicillin susceptible or not. So we've come back to the consort diagram. There's less patients now, so 281 were randomized to either flucloxacillin or benzylpenicillin, and these all had to be confirmed on that plate to be penicillin susceptible. And if we just jump now to the primary outcome, we found a higher mortality with flucloxacillin of 21.5% and 13.8% with benzylpenicillin. And again, that adjusted odds ratio is 0.67. A reminder that less than 1.0 is benzylpenicillin in this case is better. The non-inferior posterior probability now is 96% and 89% for superiority. So this is not as tight because our numbers are not as large as for the methicillin susceptible Staph aureus. And again, we can provide a graphical representation of this, and we can see that most of the distribution lies to the left of that dotted non-inferiority line. Once again, with acute kidney injury, 21.6% with flucloxacillin, and 10.9% with benzylpenicillin. And the adjusted odds ratio here is 0.5, and very high probabilities for both non-inferiority and superiority of benzylpenicillin compared to flucloxacillin. And our conclusions here is that penicillin susceptibility is real. It is a bit controversial in our field whether you can trust what the laboratory is saying. And we've demonstrated that penicillin susceptibility testing using this confirmatory phenotypic testing can be safely used to guide treatment. And in fact, benzylpenicillin is highly likely to be better than flucloxacillin. The only caveat is that there is additional complexity for the lab to test for penicillin susceptibility. So for the SNAP trial, we've been publishing as we go. We've showed you the two major results publications, but we've published a lot of our protocols for all the different parts of the trial. We have published about our statistical approach to be very transparent about that. We've also published about the neglected population groups that we've tried hard to include in the trial, including pregnant participants, and as I've mentioned, we include children as well as adults. We've also tried to include low middle income countries. At this stage, it's only a couple of sites in South Africa. And finally, we include consumers. So we've been asking them how best to do consent. We've been asking them about their perceptions on the use of intravenous versus oral antibiotics. And we have some laboratory studies which have been conducted as well. What are some of our future domains? So I've mentioned some of the results and what we have set up so far. We can introduce new domains because it's a platform trial. And here are some of the additional interventions that we'll be looking at, including antiplatelet agents, anticoagulation agents, bacteriophages, so viruses that attack the Staph aureus, an echocardiography domain, and an additional antibiotic called fosfomycin. Has this made any difference so far? As I've mentioned, we have an observational registry for patients who are not randomized, not part of the randomized part of the trial. So this is some data just from Australian sites within SNAP. The vertical lines, purple lines, refer to times when we're asked to close the domain, when we reported preliminary results back to our sites. And then the third vertical line is when we publicly reported the results at the ESCMID Global Conference. The red line is the proportion of these patients who are receiving cefazolin, and the green line is those who've been receiving flucloxacillin. So you can see that as the trial has progressed and as we've gotten to results within our trial sites, there has been almost immediate change in the use of these two drugs. And now that our results are actually published, there are some countries who are introducing cefazolin to national formularies or changing hospital formularies. We've updated the up-to-date guidelines and also other national guidelines. And in Australia, we think that there's about 25 sections of our therapeutic guidelines, antibiotics guidance that need to be updated. Finally, there's many people who are involved. We have a global trial steering committee. My chief coordinating investigator is Joshua Davis from Newcastle in Australia. And there's been enormous numbers of people involved. So that New England Journal of Medicine paper has 238 authors, and everyone has made a contribution. So there's many people on working groups. There's many sites who are involved, and all the investigators and trial staff at each of those sites. And of course, our funding bodies, which are on the right here, our trial sponsors in each region of the world, and all the participants and their family and friends. Thank you. I'm happy to stop and take questions.
Thank you very much, Steven. I think that was really an impressive summary of an even more impressive study network or platform. So, and I can confirm what you've just said on one of the last slides. That also in Germany, we actually had difficulties in getting cefazolin for quite some time because the entire world changed its prescription paradigms based on that. So congratulations once again. Really fantastic work, and especially in the field of infectious disease, where we are always criticized, right, that the numbers are not like close to maybe 5% of the patients recruited in cardiology trials. That finally we're getting more fond evidence as well. So really fantastic work. I think there are many questions related to that. Maybe I might start with some of them. In practice, I'm frequently asked with regard to the cefazolin dosing, shall we go, because everybody still remembers that for flucloxacillin you frequently went for the higher dosing. So whether to use 3 times a day, 2 grams, or even 4 times a day for some indications. So what would you recommend there based on your data?
Yeah, that's a very good question. So in our trial, most would have used 2 grams 8 hourly, so 3 times a day, 6 grams in total. But we did make some recommendations that patients in the intensive care unit with augmented renal clearance may decide to go to the 4 times a day, so 2 grams 6 hourly rather than 8 hourly. We have done a little bit of PK studies in the background that has recently been submitted to a journal, and that suggests that yes, for those with augmented renal clearance who are critically unwell, we might choose to go to the higher dose, the 2 grams 6 hourly. You're more likely to reach the percent target attainment for that patient group in that case. Whether that makes a difference clinically, we can't really say at this stage, but in my practice, I will increase the dose for that critically ill augmented renal clearance patient group.
Okay, thank you. And then we've seen in that New England paper that you also had like a very realistic or to be expected source of Staph aureus infection in most of the sites. So, I mean, I also now always wonder if you have, for example, osteomyelitis, but due to Staph aureus without bacteremia, for example, can we reasonably say yes, we'll also go for cefazolin? I think that would also be an important question, like for those deep-seated infection without bacteremia.
Yeah, very good question. And this is obviously now an extrapolation beyond the trial. The trial speaks only to patients with Staphylococcus aureus bacteremia. But I would argue that what the toxicity, at least, that we see with cefazolin versus flucloxacillin is probably going to be true, whatever condition you're treating. It doesn't have to be Staphylococcus aureus bacteremia. And so in my practice, at least now, I very, very rarely use flucloxacillin. So all those other indications where fluclox used to be perhaps first line, I've shifted to cefazolin because of this toxicity effect, which I think is a drug effect, not because of the underlying condition. And others may vary in their opinion on that, but that is my view.
Right, thank you very much. And maybe like a last one with regard to those specific drug selection process, but with regard to CNS infections, I think that was in the range of 4 or 5% in the trial. And there's also been, I remember, quite some debate in the past. Does flucloxacillin reach sufficient levels? What about cefazolin, or should we use something else, linezolid or whatever in addition? So how would you do that in clinical practice?
Yeah, so in fact, it wasn't, I don't think it was 3%, it was like 3 patients had true CNS infections in the trial. So obviously the trial cannot speak directly to that patient group, it was too small. The PK studies outside of this study suggest that drugs like flucloxacillin are actually very poor at penetrating into the central nervous system. And cefazolin may be reasonably poor, but no better. Oh, sorry, flucloxacillin is definitely no better than cefazolin. So we were quite comfortable in the trial having that as those patients could be included. So CNS infection was not an exclusion for the use of cefazolin. And that continues to be my clinical practice as well. I'm comfortable to use cefazolin. There have been some articles written. I think Erin McCreary led a nice paper in CID 2 or 3 years ago that busts the myths. There's, I think, 10 myths that they talk about. And one of the myths is about the CNS penetration of cefazolin. Not everyone believes that yet, but I think quite a few of us in the field have moved to that stance.
Thank you. And maybe one question regarding to the second work with the PSSA penicillin treatment. Do you see that take up of that in clinical practice is as rapid as for the cefazolin, or does this well, maybe I don't call it laboratory challenge, but that additional work with the disk testing that not every microbiology lab is like having experience with that, is that influencing a little bit on the velocity of the take up of that change?
Yes, I think so. Although I think there's no role for flucloxacillin in the penicillin susceptible Staph aureus. The question that remains is, should we use cefazolin or should we use penicillin for that group? And of course, we didn't randomize patients to that, but if a lab is not testing for penicillin susceptibility and they're just calling it methicillin susceptible, then those patients will probably go into cefazolin, and that is an easy choice. You don't need the lab to have to test for that. If the lab does decide to test for it, then I'm very comfortable either benzylpenicillin or cefazolin to be used for that patient. So I think that definitely does impact upon the uptake. There are some countries such as Sweden where those rates of penicillin susceptibility continue to increase. There might be even 40, 50%. So there, in that country at least, there has been a high uptake of penicillin testing that would then allow them to use benzylpenicillin. And they're, in fact, I think, quite interested in, I think actually it's more randomizing the cefazolin versus flucloxacillin. So you don't need to ask me the exact reasons why, but they are doing the penicillin testing that allows them to use benzylpenicillin in that case.
Okay, thank you very much. And any role for flucloxacillin still remaining? You said you don't use it in most of the instances. We observe a very similar pattern here, but is there like any subgroup or so where you would state maybe there might still be a small niche role for flucloxacillin?
Yeah, good question. I think I have prescribed flucloxacillin once in this past year, whereas previously every week, right, we'd be prescribing flucloxacillin. The one time that I have has been a patient who has failed cefazolin. So they may have received 6 weeks of treatment with IV cefazolin, and then that's been stopped. And maybe 1 week later, the patient has relapsed and come back with the relapsed staph endocarditis or deep joint or bone infection that clearly there's been medical therapy failure with cefazolin. Now, maybe that is due to the cefazolin inoculum effect. I can't tell because we don't test for that in a standard clinical laboratory, but maybe. And so because of that, maybe for that patient, I used flucloxacillin.
Okay, thanks very much for that clear answer. And then maybe we move over to Gunnar and Carolin for the more, I guess, nephrotoxicity related questions.
Yeah.
Thank you.
Yes,
I
thank
won't
you.
have as good answers in this case.
Yes, because I think as nephrologist, I have to ask about the acute kidney injury that was observed. So, do you know why flucloxacillin is nephrotoxic, or why we observed, or you observed this in this study? What is the underlying pathophysiology? Why flucloxacillin usually is no antibiotic that we known as critical nephrotoxic, like vancomycin, for example. So do you have an explanation for this?
I don't actually, to be honest, and it's the first question that every nephrologist asks. What is the mechanism? Of course, in our study, we're not designed to necessarily understand mechanism. We have just observed, and we collected baseline serum creatinine. We collected, asked sites to collect regular serum creatinines after that. So, and that was done for all patients. So this is not a bias that clinicians might have been more concerned about acute kidney injury with flucloxacillin and therefore collected more serum creatinins. No, we asked for serum creatinins for all patients. And so I think this is a real effect. There is some, the hydrophobicity or hydrophilicity of the two agents does differ a little bit. So that may then impact upon uptake within the renal tubules and within the renal cells. So that's still, to me, a little bit theoretical, and it's probably left maybe up to clever renal physicians to try and work out what the actual mechanism is. We have seen this in some rat studies that perhaps there is a bit more kidney injury with flucloxacillin compared to other drugs. We have also seen this when we've combined it with vancomycin. So patients who receive vancomycin versus vancomycin plus flucloxacillin, there's a very clear signal of increased acute kidney injury again with that combination therapy. We also have data from a separate clinical trial, so the Cloceba trial, which was run from France, which asked a very similar question. They randomized about 200 or 300 patients to cloxacillin or cefazolin, and they also saw increased risk of acute kidney injury. So I think it's a very true signal, but I can't really say what the mechanism is. I think I can say it's not acute interstitial nephritis or allergic interstitial nephritis. This has come on too early. It's not one of the later manifestations.
And one second question, I think you mentioned it, but in the Schneppe trial, the patients on renal replacement therapy were not part of the study. Is there any explanation for that? Because usually patients with renal replacement therapy cannot have acute kidney injury. Why was the study designed like this?
Yeah, it was because all of our investigators felt that cefazolin 3 times a week post-dialysis is such a good treatment that we weren't willing to randomize patients to flucloxacillin, which still needs to be given, 3 or 4 times a day. It's one of the other things with flucloxacillin is it's quite thrombophlebitic, so it can cause phlebitis of the veins. And so again, in a renal dialysis population, we felt that we couldn't justify the potential damage or injury to the precious veins that those patients have. And so because cefazolin is such an easy to give regimen as the 3 times a week post-dialysis, we weren't willing to randomize patients to flucloxacillin in that case. And that was the reason for the exclusion.
And one last question from my side, when we have an expert for Staphylococcus aureus here, usually we nephrologists, when we have patients on dialysis with catheters and they have high inflammation parameters or some other looks like they are going to have a sepsis or something like this, we usually start to giving vancomycin single shot. But if there's any rationale for it when we never have an MRSA before, or is it too much and we should give cefazolin instead?
I think that depends on your local epidemiology. If your local epidemiology is that 20% of your staph aureus is MRSA, then you should use vancomycin, right? But if your local rate is 1%, then I think it makes sense to use cefazolin. And in between, you can decide.
May I just come back because this is so important for us in clinical practice with our HD patients. So you would recommend us for regular HD patients who need antibiotics because of MSSA to go for 3 times a week cefazolin. So that would be the treatment standard because we still go for 1 dosage each day, but 3 dosages a week would be fine, even though there would be, say, 72 hours in between during the weekend.
Yeah, there is some good PK or pharmacokinetic data to suggest that dosing that 3 times a week post-dialysis achieves and maintains sufficient levels. So there's published papers, and there's probably a few of those now, and for many of our sites, that would be the standard treatment in dialysis patients with good outcomes. We do plan to, obviously all these patients who didn't get into the trial on dialysis, there's plenty of those. We do plan to describe what happened to that 400 or 500 patient group as well. So we should have some at least observational data to support what I'm saying as well.
This would be very good for our healthcare managers here because they always urge us to have the patients for fewer days in hospital, and this will surely allow us to have them as outpatients. So thanks so much for this information. And then you wrote a great JAMA review article on this topic. And I just would like to come back on the idea. So we have a patient and the lab calls us telling us that there's Staph aureus in the blood, and we do not yet know whether or not this is MSSA or MRSA. And this kind goes back to Carolin's questions, but in which case would you recommend us to start with vancomycin or daptomycin maybe, if there's any preference between the two of them? And in which cases would you say, well, we expect the germ to be MSSA and we can go for the cefaclor?
Yes. So it does depend on your local epidemiology and the risk factors for that patient. If the patient has previously been colonized or known to have MRSA infection, then you would choose vancomycin. If it's a patient perhaps who has recently been hospitalized and had surgery, again, you might choose vancomycin. But again, if you're from a country or from a city or your hospital has very, very low rates of MRSA, then it would be probably very reasonable to use cefazolin by itself. In my instance, where our rates of MRSA are somewhere between 10 and 15%, I will often give both drugs actually for that first 24 hours because I want to give the best coverage for MSSA as possible, but I also want to cover for MRSA in case that is the infecting organism. I think it's probably safe, particularly with cefazolin. Combining vanc and fluclox, there probably does introduce a bit more nephrotoxicity, but I suspect that cefazolin plus vancomycin is probably okay. There's no good data because it's all observational to say that the combination is any better than vancomycin alone. So the observational data would in fact say that they're probably very similar. So I don't feel strongly one way or the other. You could choose to just give everyone vancomycin. They'll probably go okay. But in my practice, I will usually combine the two for that first 24 hours before I know the susceptibility profile.
Sören, would there be a germ recommendation based on the resistance or susceptibility? So are we close to Australia, or do we have higher or lower rates of resistance?
Well, it varies a little bit within country, but we're actually rather around like 5%, 6% MRSA rates. So that's why, like for the empirical treatment, in most instances, we would also start with the beta-lactam drug immediately.
And again, for clinicians who are not experts in microbiology, you told us that it's quite difficult actually in the lab to test whether or not the Staph aureus is susceptible to penicillin, benzyl penicillin. So can we just trust our lab report here, or do we have to phone the colleagues and ask them, well, did you do the right test?
Look, it depends on the lab. We have discussed this in Australia. So our labs are all either UCAST or CLSI. They're the two either American or European accrediting agencies. If they're accredited with those guidelines, they should only report back to the clinician if they have followed those guidelines, which include doing the phenotypic disc test. So our laboratories will not report on the penicillin susceptibility if they have not done that phenotypic test. So once it comes out as a formal report from the lab, then I should be able to trust it, is what my laboratory colleagues say. But I'm not sure exactly, for example, in Germany, whether you follow the exact same kind of process. So for me, if my lab rings me up and says it's a penicillin susceptible, or that's on the computer, then I will believe that and I'll be happy to use benzyl penicillin.
And then I have a more general question to the Schneppe trial network. So actually, patients who have been included were randomized in at least 2 and sometimes in 3 fields, because they were also randomized to a combination treatment, and they were also randomized to a switch to oral treatment. So the data you published in the New England Journal and the Lancet are all patients, whether or not they have been randomized to the shorter or longer treatment period, whether or not they have been randomized to the combination treatment, and we will see more data on that in the hopefully not too far future. Did I get it right?
Yeah, that's absolutely correct. And it's one of the difficulties in reporting these platform trials where you have multiple things happening. Some patients would have been randomized to oral or not oral. Some would have been randomized to the adjunctive clindamycin or no adjunctive clindamycin. But if those parts of the trial have not finished yet, then I need, and everyone else needs to remain blinded to that result. What the statistical model does is it adjusts for whether the patient was eligible for one of those other domains and what they were randomized to within that domain as well. So there are adjustments in the statistical model, but we can't at this stage provide the raw data about that because that would unblind all of us.
And before these data will be published by you from a clinical standpoint again, when would you recommend us to consider switching from IV to oral treatment with Staph aureus bacteremia?
Yeah, it's a very good question. We're up to about 1,500 patients now in that oral switch domain. We haven't been told to stop yet, which suggests to me that there's been no major safety concern, at least. There was one German trial, in fact, led by Achim Kasch, which was published in Lancet Infectious Diseases maybe about 2 years ago, where approximately 200 patients were randomized to either oral antibiotics or IV antibiotics after 1 week of IV antibiotics. And amongst that 200 odd patients, the outcomes were the same. So there was no, and it met their non-inferiority margin. So I'm in fact increasingly comfortable in my clinical practice switching patients at quite an early stage to oral antibiotics. So this has been a big dogma in infectious diseases that you need very prolonged intravenous antibiotics for Staph bacteremia, for infective endocarditis, for osteomyelitis, bone and joint infections. There's been a number of trials, the POET trial for infective endocarditis, the OVIVA trial for bone and joint infections that have been published in the last 5 or 6 years, and they all suggest or all find that oral antibiotic switch is as effective and maybe even more effective than continued intravenous therapy. So I'm reasonably happy to extrapolate that to Staph bacteremia as well now.
And which one would you choose then? So depending surely on the local situation, but is there an oral treatment that you would favor for the majority of patients?
Yeah, it's a very good question. All of these trials allowed a kind of broad selection of antibiotics. So there wasn't comparing switch to any single antibiotic. It was switch to whatever the kind of clinician chooses within some protocolized guidelines. So the safe answer is probably any of the regimens that were in those trials could probably be used safely. Sometimes we can even extrapolate beyond that. So I actually believe that those trials demonstrated the strategy of switching to oral antibiotics was safe and effective, and therefore the choice of the antibiotic can largely be left up to the clinician. Now, some of my colleagues are more strict. They say, no, you should only use those that were included in the trial. But of course, because there were so many different regimens, there might only be 10 patients who received a certain regimen and 10 patients who received another regimen. So the actual numbers are quite small to be able to support that. So I take it that the strategy is safe and effective, and then there's a bit of freedom for the individual to choose which regimen to pick.
So one last question from my part. I would have thousands of questions, but we are aware of your time, and we are hopefully seeing you back again in 1 or 2 years or so with the next results. But looking back now with the results from the PSSA domain, would you, when you would restart now, compare cefazolin with benzopenicillin rather than the penicillins that you chose for your trial?
No, because 4 or 5 years ago when we designed this, we didn't know the results right of what we know now. We have been actively considering should we reopen the PSSA part of the study and directly compare penicillin versus cefazolin now. There's lots of arguments for and against that. At the moment, I think our community has said we're not going to proceed with that, but that will continue to be a discussion point.
So thank you very much for this great summary about Staphylococcus aureus. It was great to have you here by Marcus at home. And I think there's so much more to talk about the infectious diseases or affecting the kidney. And I hope we will meet again maybe in the future, because I think there's so much more to come and so much more to discuss. Thank you for joining us, and see you again.
Well, thank you very much for having me.